Okay, the upper extremity. Here we see that we first begin by looking at the shoulder, and we found that the shoulder is actually comprised of three bones: the clavicle, scapula, and the humerus. So these are the three bones that you should know as being the things that make the shoulder functional. So first, of the three bones, we will begin looking at the clavicle. See that the clavicle connects the upper limb to the trunk of the body and provides attachments for several muscles and ligaments. The widened sternal end of the clavicle articulates with the clavicular notch of the sternal manubrium to form the sternoclavicular joint. We commonly label this the SC joint to kind of simplify, so you don't have to always say sternoclavicular joint. So anytime that you're referring to it, you can always refer to the SC joint, and that would be acceptable. Much the same way, we see that the acromial end of the clavicle articulates with the acromial process of the scapula, and this forms the acromioclavicular joint. We commonly refer to this as the AC joint, so that would be applicable as well. The medial two-thirds of the body of the clavicle are convex, meaning that they go outward. So if we were looking at something, this would be convex, this would be concave. So basically, the medial two-thirds, or closer to the sternum, are convex, so they curve outward, whereas the lateral one-third is flattened and concave anteriorly. So basically, the sternum does something like this, with this being anterior and this being posterior. Something like this. And if you actually take your hand and feel and trace your clavicle, you can see that the clavicle does indeed curve like this. So that brings us to the scapula. The scapula is a triangle or triangular shaped bone, and it's flat. That forms the posterior portion of the shoulder girdle. So it's in charge of kind of being the keystone in this to hold everything together. It has a medial, lateral, and superior margin, and we see that very well as a triangle, with this being the spine. This would be medial, this would be lateral, and this would be superior. Notice there's no inferior margin because of the point that is originated from the joining of the medial and lateral borders. The anterior surface of the scapula is called the subscapular fossa, and it's flat and concave. There's four projections of the scapula that provide attachment sites for muscles and ligaments, contributing to the shoulder girdle. So these include the scapular spine, the acromion, the coracoid process, and the glenoid process. And so without each of these four, movement of the shoulder would not be possible. So we could look for movement and not be able to actually utilize it. The scapula continued, if we continue looking at this flat bone, we see that the glenoid process is the largest of all of the projections, and it forms the lateral angle of the scapula and ends in a depression called the glenoid fossa. And so the glenoid fossa, the glenoid process is something like this, and it creates this depression. And this depression here is called the glenoid fossa, as the name implies, fossa. The shallow articular surface of the glenoid fossa joins with the relatively large articular surface of the humeral head to create the freely moving glenohumeral joint. So basically, we see that the glenohumeral joint is formed by the glenoid of the scapula and the humerus, and so that forms the glenohumeral joint. Okay, that brings us to this image, which, for simplistic purposes, this is a drawing of the shoulder girdle. And first we see that we have the clavicle. the sternoclavicular joint here and the acromioclavicular joint there. Notice on the ends of the clavicle that articulate in this joint, we have the sternal end of the clavicle here and the acromial end of the clavicle here. And notice that that's just simply based on what it articulates with, the sternum and the acromion. We have the body in the center of the clavicle, and that's pretty much it for the clavicle. The clavicle is very simplistic. On the other hand, that brings us to the humerus. Here we have the glenohumeral joint. We have the head of the humerus. Then we have the bicipital groove, greater tubercle, lesser tubercle. We have the neck. And then we have the shaft of the humerus. And that's pretty much it for the humerus as well. So let's erase everything. So that we can focus on the scapula now. So if we focus on the scapula, we can see that it does have the triangular shape, with the lateral margin being here and the medial margin being there. Notice how it all comes down into a point. That is the inferior angle. Notice that it does create a point or an angle there. We also have the superior margin here. In addition to this, we have the coracoid process, which is slightly anterior to the acromion, and posterior to the coracoid process is the acromion. And notice how it articulates with the clavicle. Additionally, we have the glenoid process here, scapular notch here, which is an indention, which we'll see visualized in future images. And just as we have an inferior angle, we have a rounded density here, which is the superior angle. However, everything tends to look vastly different in terms of CT in comparison to what you would see normally in a diagram. We do have the manubrium here. We have sternoclavicular joint, the sternal end of the clavicle, the body, the acromial end, the acromioclavicular joint of the clavicle. Additionally, we have glenohumeral joint, the head, and we don't really see any of the tubercles really visualized in terms of this. So let's erase everything. And that brings us to the scapula. Here we have the lateral margin, the medial margin, the inferior angle, the superior angle, scapular notch, glenoid process, glenoid fossa, glenohumeral joint, coracoid process of the scapula, and additionally the acromion. Okay, looking at this from a posterior portion, we see that we have the scapular spine, which leads us into the acromion. Additionally, it must be said that this is a right scapula, with the humerus residing somewhere here. This makes this the glenoid process, with this being the glenoid fossa, as we see detailed here. This is the medial border. This is the lateral border. Here we have the inferior angle. Here we have the superior angle. Here we have the scapular notch. Notice how it creates this indentation, which is fairly obvious, especially when you're looking at it from the posterior portion. Then anteriorly we have the coracoid process. Here we see what would traditionally be called a Y-view, and it kind of allows us to see what the glenoid fossa actually looks like. We see that it's just a depression created by the glenoid process. As we can see, this area here, and hopefully what looks like a thicker red line, is the actual glenoid process, with the glenoid fossa residing in the center of it. But we do see that we're looking at it from the standpoint of this being the lateral border looking towards the medial portion. Additionally, we have the coracoid process jutting anteriorly and the acromion residing posteriorly. We have the scapular notch here. Scapular spine would be here. So that brings us to what does it look like in terms of CT. Here we can see that we have the glenohumeral joint. The glenoid fossa will be defined as this area where the arrow is pointing, and the glenoid process is this area. Additionally, we have the coracoid process jutting anteriorly. We're not visualizing the acromion. If we refer to this image over here, we can see that we've just scanned past the acromion and are getting into the coracoid process. Here we have the scapular spine. Additionally, we have the humerus with the humeral head. We're going to label that as HH, residing in this area. Then we have the greater tubercle, and that's pretty much all that we can actually visualize.
Okay, on this image we have the scapula, we have the clavicle, and we have the humerus. We have the head of the humerus articulating with the glenoid fossa of, or the glenoid process of the scapula, forming the glenohumeral joint. We also have the greater tubercle here. We have the humeral head, and we have the anatomic neck residing somewhere in this area, and the surgical neck going inferior. We have the acromion articulating with the clavicle, and here we have the depression, the glenoid fossa. This image is slightly different. We have the humeral head, the greater tubercle, and the lesser tubercle here, the inner tubercle groove or the bicipital groove. Notice we have the coracoid process, the scapular spine, we have the deltoid muscle, which basically gives the shoulder its rounded shape. Here we have the anatomic neck. We have the surgical neck being inferior. We have the greater tubercle, the scapula, the acromion, the deltoid muscle, once again, we're looking at the humeral head. We have the greater tubercle, the lesser tubercle. We have the biceps tendon originating here, the deltoid muscle, the subscapularis muscle, the biceps tendon, the glenohumeral joint, here we see the clavicle, humeral head, anatomic neck, surgical neck, glenoid process, the supraspinatus muscle, the deltoid muscle, the trapezius muscle, the subscapularis, additionally, we have the axillary nerve right here and the brachial artery.
So that brings us to the humerus. The humerus we find is a long bone that articulates with the scapula superiorly and the radius and ulna inferiorly. So it's a very long bone. It consists of a body or shaft, a lower distal end, and an upper or proximal end. Two tubercle projections from the humeral head provide attachment sites for tendons and ligaments. So once again, the greater and lesser tubercle are going to provide attachment sites for tendons and ligaments. The intertubular or bicipital groove separates the two tubercles. And so basically, that is what this groove actually does, is separate the two tubercles. As you can see, it's bicipital, which means that it separates the two. The humerus has two necks, the more proximal anatomic neck and the surgical neck. And so we'll see as we look at our images that we're going to find two necks. One's going to be very proximal to the head, and another is going to be more distal and labeled as a surgical neck. Here's a diagram. Here we have the head of the humerus. Here we have the greater tubercle, and here we have the lesser tubercle with the bicipital groove residing here. We have the anatomic neck. Then we have the surgical neck residing in this area. Notice how the anatomical neck is more proximal to the humeral head, while the surgical neck is more distal. Looking at it from a posterior view, we see that we have the greater tubercle, the humeral head, the anatomic neck, the surgical neck, the shaft, which is this long portion here. And that brings us down to the distal portion of the humerus, which will articulate with the radius and the ulna. We have a cornoid fossa, and a radial fossa, which, as the name implies, radial fossa will be for the radial head, and the coronoid process, or coronoid fossa, will provide an articulation here as well. We also have the trochlea and the capitulum, which we'll see how it articulates with the radius and ulna. Both of these articulations actually occur, and how it actually works. We do see that we have a jutting out here, and so this is an epicondyle on both sides, with this being medial as the shoulder is joining the girdle this way, and this would be lateral here. Okay, looking at this image, we see that we are pretty much just slightly lower than where we were in the previous CT image that we actually saw, but it appears to be on the same patient. We have the coracoid process, scapular spine, scapular body, glenohumeral joint, glenoid process. Here we have humeral head, and we assume this to be close to the anatomic neck, so we're going to say AN. Here we have the lesser tubercle and the greater tubercle, and we see this indentation here. This little indentation is the intertubercular groove, or the bicipital groove.
Elbow, we see that we have the posterior fat pad, the brachioradialis muscle, the biceps muscle, and the brachialis muscle, the triceps muscle being on the posterior portion of the arm. Additionally, we have the basilic vein and the brachial vein and the brachial artery. Okay, so here we're looking at the deltoid muscle, the biceps muscle, brachialis muscle, and the triceps group. And so the triceps make up the posterior portion, while the biceps make up the anterior portion. Here we have the triceps muscle, the brachialis muscle, humerus here, the radial head,
So that brings us to the labrum and the ligaments. There are three glenohumeral ligaments, which we call superior, middle, and inferior, which are thickenings of the fibrous capsule that surround the shoulder joint. They contribute to the formation of the glenoid labrum. So Here we have additional ligaments, such as the coracohumeral ligament, coracoacromial ligament, coracoclavicular ligament, acromioclavicular ligament, transverse humeral ligament. And so basically, as you can see, coraco referring to coracoid process, and humerus referring to the humerus. Coraco, once again, referring to the coracoid process. Acromial, referring to the acromion. Coracoid, referring to the clavicular, or coracoid. Clavicular, referring to the clavicle. The acromioclavicular ligament means just what it says, between the acromion and the clavicle. The transverse ligament, or transverse humeral ligament, then will be crossing the humerus. So that brings us to the articular joint capsule. We see that it completely encloses the shoulder joint, and is quite thin and loose to allow for extreme freedom of movement. That's one of the things that we have to have with the shoulder, based on the type of joint that it is freedom of movement. If you don't have freedom of movement, things will fall apart quickly in the shoulder. So there are two openings of the joint capsule. The first is to allow for the transition of the long head, the biceps brachii, and the second is to establish communication between the joint and the subscapularis bursae. So you don't really have to know both of these, but just know that there are two openings to the joint capsule of the shoulder, which pretty much indicates that it's not a closed capsule. So what are bursae? Bursae reduce friction where large muscles and tendons pass across the joint capsule. We see that we have two of those, such as the subacromial subdeltoid bursa and the subscapularis bursa. The important thing to remember is it reduces friction. Friction is the enemy of the body. Anytime that you have increased friction, things are going to wear out. That's why when your knees have a reduction in cartilage, things tend to go wrong, simply because you create high stress, high tension points of the body, which the body is not capable of withstanding. So the muscles that connect the upper limb to the vertebral column. We have the trapezius muscle, and pretty much what I want you to understand from these are what the functions are. The trapezius muscle functions to stabilize the scapula as well as elevate, retract, and depress the scapula. So notice it's all about the scapula for the trapezius muscle. The levitator scapula muscle functions to elevate and rotate the scapula. So it's going to elevate and rotate, once again, the scapula. The latissimus dorsi medially rotates, extends, and abducts the humerus. So the latissimus dorsi is going to be controlling the humerus in some sense, and going to be in charge of rotating it, extending, and adducts. So bringing it back to the body is what the latissimus dorsi is going to be charged with. The rhomboid muscles, major and minor, function to retract the scapula and fix the scapula to the thoracic wall. So it's going to try and hold the scapula more so in place to the thoracic wall, so that the scapula, when things are moving, doesn't just completely impinge on the movement of the shoulder. The deltoid muscle is a powerful muscle which forms the rounded contour of the shoulder and functions primarily to abduct the arm. So function is to abduct. When you think of abduct, it means to go or remove, and adduct means to add. And so abduct means to take the arm away from the body. So extend the arm outside of the body. It adducts and medially rotates the arm as well. So it kind of functions with the latissimus dorsi muscle in the sense that it causes adduction as well, and it is in charge of rotating the arm. The supraspinatus infraspinatus, teres minor, and subscapularis muscles. They closely surround the scapula and compose the rotator cuff. When you refer to the rotator cuff, this is what you're talking about, these four muscle groups here. They are in charge of providing dynamic stability to the shoulder joint and allow for abduction, and rotation of the humerus. And so it's very important for the humerus to be able to do all of these things. And that is why when you see patients who have problems with the rotator cuff, typically they're not able to do any of these motions. Usually abduction is the hardest, and many times they don't even have the capability of raising the arm very high at all, simply because of the loss of the stability from the scapula. So the muscles connecting the upper extremity to the anterior and lateral thoracic walls. We have the pectoralis major muscle, and its primary function is to adduct, medially rotate, and flex and extend the humerus, and to assist in forced inspiration. So it also assists in inspiration. So breathing is going to be helped by the pectoralis major muscle, but its primary function is to work with the humerus. The pectoralis minor muscle acts to depress the scapula and assist the serratus anterior muscle in pulling the scapula forward. So the pectoralis minor muscle is going to be in charge of pulling the scapula forward. So the muscles of the upper arm. We have the biceps brachii muscle, which acts as a strong flexor of the forearm. So biceps brachii is the flexor. It's named biceps because of its two expanded heads of proximal attachment, long and short. That brings us to the triceps brachii muscle. It's located on the posterior surface of the humerus and is the main extensor of the forearm. So it's going to be in charge of extending the forearm. It's named triceps because it has three expanded heads, not two. So the thing that you need to keep in mind is the biceps are going to be anterior, triceps posterior. This will be utilized very well because many times it becomes very confusing where things are actually located. Many people get confused whether the biceps is anterior or posterior, and it's essential that we keep this in mind. The biceps is anterior, triceps is posterior, and that will become very, very essential when you're looking at CT images so that you can delineate which one you're looking at. Also notice that the biceps is going to be flexing the arm, and the triceps is going to be extending. So on this image, we have the acromion, and we have the AC joint here, and the acromial end of the clavicle here. On this image, I don't really expect you to know really anything on this image, as it's far too in depth for what you will actually be able to visualize in terms of CT. But just recognize the joint capsule and all of the ligaments that go into making things functional for the body. Okay, so that brings us to this image. Here we can see virtually the same as the previous images, with the glenohumeral joint here, the glenoid process, intertubercular groove here, or basilar groove, greater tubercle, lesser tubercle, acromion, scapular spine, clavicle, and also notice that there is air in the joint capsule. This is probably from an arthrogram, something like that, where contrast is injected into this joint capsule to see how it's actually performing. So, not uncommon to see this as well. Also, notice that we have the biceps tendon. Let's erase some of this. We have the biceps tendon here, and we have the deltoid. Remember, the deltoid is in charge of giving the shoulder its kind of rounded appearance, and we see that here with this muscle group, the deltoids. Additionally, we have another image where we have greater tubercle, lesser tubercle, occipital groove. We're getting into the body of the scapula now. We have the clavicle here. We have air in the joint space once again. Glenohumeral joint, glenoid process, deltoids, comprising the rounded area of the shoulder. So here we have another demonstration of the deltoids. As you can see, it gives the shoulder this rounded, sloped appearance. Also notice we have the acromioclavicular joint, clavicle, sternoclavicular joint, glenohumeral joint, glenoid process, scapular body, and then we have glenoid fossa, humeral head, anatomic neck, surgical neck, additionally on this image we have the deltoid muscle, we have the subscapularis, then we also have the subacromial subdeltoid bursa, residing just below the acromion. In relation to looking at where these muscles are, we see that we have clavicle, AC joint, scapular spine, acromion, medial margin, lateral margin, and we can see that the trapezius is the most superior, comprising a very large area. Notice how it covers a large range of thoracic vertebrae. Additionally, the deltoid muscle once again gives the shoulder a rounded appearance. Just slightly below the trapezius, we have the latissimus dorsi. Notice the location and how large this muscle is. And then, as you can see, the scapula resides below this. When we actually get into the scapula, we have the infraspinatus muscle. We have the supraspinatus muscle. The levitator scapulae, the rhomboids, So each of these serves a unique function to help maneuver the arm. But once again, things are not so clearly defined in terms of CT, so it becomes much more difficult to discern where things are located. Here we have the scapular spine, the clavicle, and we have some portion of the scapula here as well. So we have the supraspinatus muscle, we have the deltoid, the infraspinatus, which is situated in this little crevice, the trapezius muscle, so once again we have the deltoid. The deltoid should be fairly easy to discern. We have the supraspinatus, clavicle, coracoid process, humeral head, scapular spine, trapezius muscle lying posteriorly as well, and that's pretty much it for this area. Once again, we have the deltoid, scapular spine, subscapularis muscle, infraspinatus muscle, trapezius, also notice the pectoralis major muscle, which at this point is lying just anterior to the clavicle. So here is the pectoralis major, pectoralis minor, deltoid, trapezius, subscapularis, infraspinatus, teres major, and teres minor. Okay, here we have the supraspinatus fossa, where the supraspinous muscle will reside. Here we have the infraspinatus muscle. And as you can see, the infraspinatus muscle is attaching to the greater tubercle. So this is something that will become essential so that you can better understand where everything is located in terms of CT. So notice we have the ribs coming in. We have the humeral head, the glenoid fossa, the glenoid process. We have occipital groove, with the greater tuberosity and the lesser tuberosity. And so we have the infraspinatus muscle, subscapularis, the deltoid, pectoralis major, and then slightly posterior to the pectoralis major we have pectoralis minor muscle. Notice how much smaller it actually is. Here we are looking at an anterior posterior view, or an AP view, and we can see that we're looking at the biceps brachii muscle. As you can see, we have two heads, additionally we have the greater tubercle and the lesser tubercle, and as you can see, one of the heads of the biceps brachii actually resides in the inner tubercle groove, or the bicipital groove. The other attaches to the forefold process here. We're not going to worry about this image, so just draw a line through it. You won't have to worry about this one. Venturing down the arm, we see that we have biceps brachii muscle, the deltoid muscle, so we're just a little removed from the actual shoulder. And then we have the triceps muscle, comprising the majority of the posterior portion of the arm. Also take notice of the brachial artery here and the basilic vein there. Going down even farther, we have the triceps, now comprising solely the posterior portion of the arm. So as you can see, the triceps makes up a very large portion. The biceps, as you can see, you have two heads here, or two portions of the muscle, whereas you have three for the triceps. Then we also have brachialis muscle. But don't really worry about the brachialis muscle. Here we also have the brachial artery. Notice how it's kind of enlarged, and the basilic vein. Getting almost to the elbow now, you see that we have the triceps, the biceps, the brachialis muscle, the brachioradialis muscle, and the extensor carpi radialis longus muscle. But pretty much what you need to understand from this image is what I actually have highlighted in purple. We also have the brachial artery and the basilic vein. Notice how the basilic vein and the brachial artery have kind of separated now. So using what we know, we can see a little more in terms of CT. We have the deltoid muscle here, the triceps, pectoralis major, pectoralis minor, latissimus dorsi, as you can see now, we're slightly more distal than about mid-shaft. And we can see that we have the biceps brachii muscle, the brachial vein, the basilic vein, cephalic vein. We have the triceps making up the most inferior portion, and then it would be safe to say that we have the brachialis muscle comprising the majority here. Now, down at the elbow, we see that we have the biceps muscle, the triceps muscle, the brachioradialis muscle, and the brachialis. Additionally, we have the brachial artery, brachial vein, cephalic vein, basilic vein. Okay, the elbow. Firstly, the elbow is a hinge pivot joint, which pretty much means that you can straighten and bend the elbow, but you can also rotate it to some degree. We see that the radio-ulnar and radio-humeral articulations create the pivot joint that aids in supination and pronation of the elbow. So without these two joints, the radio-ulnar and the radio-humeral, there would probably be no way to articulate the elbow other than possibly flexion and extension. The pronation would be impossible. So if we look at the distal humerus, we see that the distal portion of the humerus has two distinct prominences termed the medial and lateral epicondyles, with associated epicondyles that provide attachment sites for the tendons and ligaments. So if we just kind of refer to a drawing, we see that this area and this area are the epicondyles, and they're charged with providing attachment sites for tendons and ligaments. The distal humerus has two cartilage-covered articular surfaces, which are the capitulum and the trochlea, for articulation with the radius and ulna. The trochlea is more medial and has the appearance of an hourglass if viewed in the horizontal plane. So we then move into the proximal radius. The radius is a long, slender bone with a proximal portion that consists of the radial head, neck, and tuberosity. So the head of the radius and the neck and the tuberosity are all going to be proximal, meaning that they're going to be closer to the elbow. The radial head has a flat cartilage-covered depression or fossa. The articular circumference of the radial head articulates against the radial notch of the ulna during supination and pronation. The radial tuberosity serves as an attachment point for the biceps brachii muscle. So keep that in mind. The radial tuberosity is going to have something very important, and that is an attachment point for the brachii, or biceps brachii muscle. The distal radius, we find that the ulnar notch articulates with the ulna. The styloid process serves as an attachment site for the extensor pollicis longus and extensor carpi radialis tendons. So many times the styloid process are looked at as being non-essential, but they do serve as an attachment site and prove to be very essential. Radial dorsal tubercle, or Lister's tubercle, is a common site for formation of bony spurs. You want to star this I won't actually probably ask you to find what or where this typical is, but I will ask you probably what is a common site for the formation of bony spurs in the wrist, and that'll be something that I will ask you to refer back to. So the proximal ulna. So we're once again at the elbow. The proximal ulna consists of the olecranon and coronoid processes and the trochlear and radial notches. The trochlear notch allows for flexion and extension of the elbow. So we'll see how this actually works when we get images. The radial notch is covered by an articular cartilage for articulation with the radial head. So as we'll see, the radial head will look something like this, and this notch is going to allow articulation and also allow supination so that this can kind of rotate inside of it. So the distal ulna, the ulna as we get towards the wrist is going to become very small or smaller, and we'll have two prominent projections. The head of the ulna will be at the wrist, as well as the ulnar styloid process. So you're going to look for two things at the distal portion of the ulna. So the joint capsule and fat pads. So the entire elbow joint is surrounded. Okay, so that brings us to joint capsule and fat pads. You've probably heard of fat pads, and when there's an abnormality, usually you'll see disruption in the fat pads. We see that the entire elbow joint is surrounded by a relatively loose joint capsule. It allows for the movements of flexion and extension, but it also allows for rotation as well. Located within the olecranon and coronoid fossils are fat pads that fill the space between the synovial membrane and the joint capsule. So I kind of think of the fat pads being a type of insulation in this sense. The fat pads help to cushion the area where the olecranon and the coronoid processes move during flexion and extension of the elbow. So they also act as the cushioning effect. So the ligaments. The ulnar and collateral ligament, which is the medial collateral ligament, consists of three components: the anterior band, posterior band, and the transverse band. The anterior band, which is the strongest, extends from the medial epicondyle of the humerus to the medial aspect of the coronoid process. The posterior band originates along with the anterior band from the medial epicondyle of the humerus and inserts on the medial aspect of the olecranon. The weaker transverse band stretches between the medial surfaces of the coronoid and olecranon processes to unite the anterior and posterior bands. That brings us to the muscles of the forearm. And as you can guess, there are an extensive list of muscles. These muscles act to extend, to flex, to even move the wrist, hands, things like that. So these are very extensive and very important. So the first one that we're going to look at is the pronator teres muscle. And it works in conjunction. So it means that it works together with the pronator quadrates muscle to pronate the forearm. So as you might guess, the name pronator means that it's going to pronate the forearm. So just simply know the function. The flexor carpi radialis muscle, its actions include the flexion and radial deviation of the hand at the wrist joint. So when you perform sometimes maybe a radial deviation, this is the muscle that will be worked, and also flexion. The palmaris longus muscle acts to flex the hand and tighten the palmar aponeurosis. And so basically, flexion of the hand, once again. Okay, the flexor carpi ulnaris muscle acts to flex and adduct the hand at the wrist joint. And so, flexion and adduction of the hand. The flexor digitorum superficialis muscle is the strong flexor of the middle and proximal phalanges of the 2nd through 5th digits. So we're looking at the middle and the proximal phalanges of the 2nd through 5th digits. So this is what's going to cause a lot of your finger movements. The flexor digitorum profundus muscle provides flexion of the middle and proximal phalanges of the 2nd through 5th digits. So it kind of shares this load as well. So we're doing flexion, middle, and the proximal phalanges, 2nd through 5th. Flexor pollicis longus muscle, we're not going to worry about function there. The pronator quadratus is the prime mover in pronation of the forearm. So the pronator quadratus, once again, is concerned with pronation. We also saw the brachial radialis, which flicks the forearm at the elbow and assists with pronation and supination. So the brachial radialis is going to be for flexion and pronation and supination. The extensor carpi radialis longus muscle acts as an extensor and abductor of the hand at the wrist joint. So we see, because it is an extensor, its function is going to be extension, but it also functions as an abductor of the hand. The extensor carpi radialis brevis acts to extend and abduct the hand at the wrist joint. So we see that the longus and the brevis are functioning pretty much for the same reason. The extensor digitorum muscle spreads the fingers and extends the hand. So, spreads the fingers, extends the hand. The abductor pollicis longus muscle acts to abduct and extend the thumb. So, we're getting into movements of the thumb now. So, abduct and extend the thumb. The extensor pollicis brevis muscle works together with the abductor pollicis longus to extend and abduct the thumb. So, the extensor is going to be working with the abductor. The extensor pollicis longus muscle, its main action is to extend the distal phalanx of the first digit, but can also abduct the hand. So this muscle is going to be concerned with the extension of the distal phalanx of only the first digit. The extensor indicis muscle functions with the extensor digitorum muscle to extend the index finger. So it's working for the index finger. The supinator muscle functions to supinate the forearm. As the name implies, supinator means that it is functioning for supination. So let's begin looking at some images. Okay, so looking at our images, looking at the drawing initially, we have the ulna and the radius. And so basically, we see that the radius is on the thumb side if you are in supination. But also, we see that the radius is on the lateral border. And the ulna is more medial. So if we begin by looking at just the radius, we see that the radius has kind of a cap-like area to it, and that is the head. Directly below the head, in this area here, is the neck. And so we do see that we have a jutting out of the radius, and that is the radial tuberosity. As we continue down the shaft of the radius, we get to the end, and we have a radial styloid process, or styloid process of the radius, right here. If we then begin looking at the ulna, we'll see that we have an olecranon process, which is this elevated area here. Then we have a coronoid process, right here. And so if you were to look at the olecranon process, you would see that it has an indentation something like this. That is the trochlear notch, which allows articulation with the humerus. As we continue down the ulna, we see that we reach the head of the ulna, which is this area here, with a jutting out to match the styloid process of the radius, and that is the ulnar styloid process, or the styloid process of the ulna. Now, if we were to look at it from a posterior view, we would see that we have the olecranon process being the most superior portion, or the most proximal portion of the ulna. The radial head here, radial neck, radial tuberosity somewhat hidden by the ulna. We see the styloid process of the ulna, styloid process of the radius, ulnar head, and also notice the radial dorsal tubercle, or Lister's tubercle. That's this area right here. So if we begin by just looking at the elbow joint in itself, we see that we have the humerus coming in, and so we're seeing the distal humerus and the proximal radius and ulna. We see the olecranon process, or the coronoid process here. We see that we have the trochlea sitting inside the trochlear notch, and we have the capitulum articulating against the radial head. So the capitulum is this. So this is capitulum, this is the trochlea. We do have the radial tuberosity, and we also have an ulnar tuberosity, which was not seen in the previous image. Here we have an epicondyle and an epicondyle. This is the medial epicondyle here, and this is the lateral. Remember, the radius is on the lateral side, so that'll help keep everything straight. So here we see an elbow in terms of CT. As you can see, this is performed with the arm fully straightened, or as much as the patient will allow. And we see that we have the humerus here, and this is the ulna. And so we have the olecranon fossa of the humerus being where the olecranon process actually goes into. We have the epicondyle here, and we have here. These are the lateral and medial epicondyle. And so we're seeing the ulna and the distal portion of the humerus. Here is just a little demonstration of where the fat pads are actually located. You see one fat pad here, another fat pad here. And then you also see subcutaneous fat here. And so When you hear of trauma to the elbow area, usually you're going to look for fat pad displacement, because if you actually have trauma to the distal portion of the humerus, it should displace some of the fat pad. That's one of the sure signs of trauma to an elbow region. Also notice that we have the triceps coming in. We have the brachialis muscle coming in. Also notice that we have the olecranon fossa here. We have the trochlea. We have the coronoid process and the olecranon process here. Here we can see this area and this area, and those are the fat pads. We have the anterior fat pad and the posterior fat pad. We also have the brachioradialis muscle, triceps, here is a demonstration of how the elbow is actually held in place. We have several ligaments. We have the ulnar ligament, kind of going over the radial head. And then we have the transverse band, the anterior band, the posterior band, trying to help hold the elbow in place. And so the transverse, anterior, and posterior bands all are unified under an umbrella called the ulnar collateral ligament. And so that's what we're focusing on here, is the ulnar collateral ligament, which is the transverse, anterior, and posterior bands. Okay, so here we see the olecranon process. We have what looks to be the olecranon fossa, medial, and lateral epicondyles. We have brachioradialis muscle, biceps, or the brachialis muscle here, the biceps up here, and that is pretty much it for this image. Okay, here we have the crossing over of actually getting to simply the radius and the ulna without the humerus being involved. We have the brachioradialis muscle here. We have the ulna and the radius here. Notice how we have a curved shape, which means that this is probably the radial head. This area here is probably the humerus, or the last portion of the humerus. We're probably seeing this being the capitulum, this little area here. We're looking at ulna, and judging by our plan up here, it looks like we're getting ready to see the coracoid process, or the coronoid process, and continuing on down the shaft of the ulna. This image is a little hard to define based on what we see. We have the brachioradialis muscle. It says radius here, and it looks like we have some degree of separation, so this is probably the radial head or the radial neck. Looking at the ulna, and this is all you really need to know from this image. Here we're actually going down mid-shaft, and so you can see that this patient doesn't necessarily have their arm completely supinated. It's actually kind of at an oblique angle, and we can tell this because of how the bones are overlaid. They should be pretty much separated, and we're seeing the ulna and the radius. And so, judging by this, the patient is probably, they may have their hand turned in kind of an oblique, or they may actually have their hand turned in what looks to be a lateral formation. But we can see the cephalic vein, median cubital vein, and the basilar, and the radial artery, but you won't probably see any questions regarding this at all, because it becomes so tedious to actually figure out where things are. Here, on the other hand, we have an image that, judging by our planning view over here, that we're getting into the wrist. And the reason we can assume this is because this is the radius, this is the ulna, and notice how large the radius is in comparison to the ulna. And we know that to be true. Notice we have this little bony prominence here that's kind of sticking up. This is Lister's tubercle. We're not going to worry about the ulnar artery, cephalic vein. The only thing we really need to be concerned with is the radial artery, which is here. We have all of these tendons here, and it becomes very tedious to actually identify each and every one of these tendons in terms of CT. This brings us to the wrist and hand. The bony anatomy of the wrist and hand consists of the distal radius and ulna, 8 carpal bones, 5 metacarpals, and 14 phalanges. The proximal row of the carpal bones are the scaphoid, which is sometimes called the navicular, the lunate, also called the semilunar, traquetral, also called the traquetrium, the pisiform. The distal row, then, of carpal bones contains the trapezius, the trapezoid, the cavitate, and the hanoid. The 5 metacarpals are small tubular bones with proximal end called bases, distal ends called heads, and a space in between called shafts, or the body. So in terms of joints, the distal radial ulnar articulation, such as the distal radial ulnar joint, is created when the ulnar notch of the radius moves around the articular circumference of the ulna, providing the movements of supination and pronation. The main stabilizing element of the DRUG, or J, of the distal radial ulnar joint is an articular disc called the triangular fibrocartilage complex. The midcarpal joint is formed by the articulation between the proximal and distal carpal row. The articulation between the carpals within each row creates the intercarpal joints. The carpal metacarpal joints are formed by the articulation between the carpals and 5 metacarpals. The intermetacarpal articulation exists between the base of the metacarpals and is joined by the palmar and dorsal metacarpal ligaments. So the ligaments and fascia. The extrinsic ligaments reinforce the joint cavity surrounding the carpal region and include palmar and dorsal radial carpal ligaments, the radial and ulnar collateral ligaments, and the TFCC. The carpal tunnel is created by the concave arrangement of the carpal bones. A thick ligamentous band called the flexor renactum, or the transverse carpal ligament, stretches across the carpal tunnel to create an enclosure for the passage of tendons and the median nerve. So basically, what I would like you to know is what the carpal tunnel is and how it is created, and what the flexor renactum actually does. The numerous muscles of the forearm become tendinous just before the wrist joint. The many tendons located in the wrist can be divided into palmar and dorsal tendon groups. The palmar tendon group collectively flexes the fingers and wrist. So palmar flexes fingers and wrist. The muscles of the hand can be divided into 3 groups: the metacarpal group, which are the central muscles of the hand; the thenar group, which are muscles involving the thumb and creating the thenar eminence; and the hypothenar group, which are muscles involving the 5th digit and creating the hypothenar eminence on the ulnar side. So that brings us to images. So here we have kind of a little different view, I guess you would say. We have a dividing line between the superior and distal, or proximal and distal rows of the carpal bones. We see the more proximal row contains the scaphoid, lunate, here we see pretty much the distal radius and ulna, as well as the carpals and the proximal portion of most of the hand. So we see, starting with the radius and ulna, we have the styloid process and the styloid process. We have the radius with what appears to be a fracture in it. We have the ulnar head. Then we have the scaphoid, lunate, pisiform. We have triquetral, hamate, capitate, trapezoid, and trapezium. And then we have carpal metacarpal joints. In between each of the carpals is the intercarpal joints. Here is the radial, or the ulnar carpal joint, and the radial carpal joint. Here we have the thumb, index, middle, and this would be your ring finger, and this would be your pinky, or 1, 2, 3, 4, 5 in terms of numbering. Here we can see that we have the first metacarpal, second metacarpal, third metacarpal, fourth metacarpal, fifth metacarpal. Also we have also some sesamoid bones here. As we can see, this is a scan through the distal row of the carpal bones. We have the hamate. You can see the hook of the hamate here. You have the capitate, the trapezoid, and the trapezium. And notice we have the first metacarpal here is going to be articulated. Here we have the intercarpal joints, and you can argue that this would be the tunnel here, even though the book doesn't label it. Notice that this is far more accurate and advanced than anything you've probably shot in terms of wrist views for just plain radiography. So here we're going into out of the distal row and kind of going into the proximal row. Notice we can see a little bit of the pisiform here and a little bit of the scaphoid. And that's exactly what we see here as well. We see a little of the pisiform. We're seeing some of the scaphoid. We're seeing the capitate, the hamate, and the trapezoid. Okay, here we have the radius. We have the styloid process of the radius. We have the capitate, which is very large. The hamate, which is almost as large. The pisiform, which is slightly smaller. The lunate. The scaphoid. The scaphoid will be very easy to define because of the shape, the kind of curved shape that it has. The trapezoid, trapezium. And then we have trapezoid there as well. However, because we are kind of going at this at an oblique angle, it kind of skews this, and so it makes it very hard to define really what you're looking at. So if you were to see this on an exam, it will be very obvious. We will have I will label where your fingers are, like this would be number 2, 3, 4, or 5. Here would be 4 probably, and so this would make this 5. 1 would be here, and I would label something to the effect of distal row and then proximal, so that you can easily define where you're at. So here we have a demonstration of the rows. Interestingly enough, it leaves out the pisiform, but we have the proximal row and we have the distal row. So in the proximal we have the scaphoid, the lunate, trapezoid, and the pisiform. And then in the distal row we have the trapezium, trapezoid, capitate, and the hamate. And so notice how the proximal row has a tendency to follow this curvature of the wrist so that it fits very nicely in where the radius and the ulna create this kind of arch shape. Here we have a styloid process on both the radius and the ulna, with the ulnar head here. Notice that we have articulations between the first through the fifth digits. Here are the carpometacarpal joints. So that brings us on up into the fingers. We're not going to worry about any of the tendons because that is far beyond the scope of what we're trying to accomplish here. But we have first metacarpal, second, third, fourth, and the fifth metacarpals.
So in this image, as we're going down in through the forearm, we have the brachioradialis muscle, we have the radius and the ulna, we have the flexor digitorum superficialis muscle, we have the extensor radialis brevis muscle, we have the supinator muscle, we have the flexor digitorum profundus muscle, the pronator teres muscle, the palmaris longus muscle, and going on into the next image, we have many more different muscles, and it's quite impossible to actually know the location of each one of these muscles. We're going to worry more about what each muscle does that we've named than where their location is, because it becomes very, very tricky to analyze where each of the muscles begin and end in this respect. Here we have an image of the wrist. So here we have the scaphoid, the lunate, the triquetrum, we have the ulna and the radius, we have the base of the second metacarpal. We have the scaphoid, the lunate, triquetrum, we have the hamate, capitate, trapezoid, and the trapezium. Additionally, we have the base of the first metacarpal. We have the radius and the ulna. We have metacarpal phalangeal joints, interphalangeal joints. This is the proximal interphalangeal joint. Here are all of the metacarpal phalangeal joints that we have here, here, here are the interphalangeal joints that we have as well. And here we have the artery systems that supply the hand. Notice we have the radial artery coming in, and the ulnar artery, and how they supply the hands and the fingers.
That brings us to the circulation. This is a venous system here. We have the cephalic vein coming down, the median cubital vein, basilic vein, cephalic vein, Additionally, here is the arterial system. We're coming out of the left subclavian, and we're going down. The left subclavian becomes the axillary artery. Then from the axillary artery, it becomes the brachial artery, and then it continues on, and we become the radial and ulnar arteries. And then we get into the capillaries and that. So basically, this is why it's important to notice what is coming off your aortic arch, because you will know that this is the innominate trunk here, or the brachiocephalic trunk for the subclavian and the right common carotid. You'd have the left common carotid and the subclavian. And that is it. If you have any questions, feel free to shoot me an email at tmassengale0002@kctcs.edu. Thanks.